Okay, we got a doozy here with our first labs. Question number 7. Which of the following is the most likely cause of this patient's condition? Again, unhelpful, unfortunately. Let's quickly look at the answer choices. Androgen use, high affinity hemoglobin, JAK2 mutation, chronic hypoxemia, pyramidal plot. Okay, I'm still kind of lost. I don't really know what this is about. Even after looking at that, maybe something to do with genetics, maybe heme? Probably heme. It's if I were to guess. So, okay, now we're going to go ahead and read through the question. 52-year-old man presents with 3 months of headaches, fatigue, itching after hot showers. That is, I mean, if you've ever heard of this symptom, itching after hot showers, if you've ever heard of that, you probably know what the answer already is. This is a big buzzword that we'll come back to later. He reports facial redness, occasional blurred vision, early satiety, does not smoke, lives at sea level, has no known lung or heart conditions. Labs. The labs are really important too. Hemoglobin, first one, is 20. It's pretty good. I've seen better, but we're over the high end of the reference range here. We're above, we're always used to seeing anemias, which are below. We have the opposite of anemia. Again, if you've ever heard of this condition, you know what the diagnosis is, right? The diagnosis should not be very hard to get out of this. Hematocrit, 61%. Again, we're above the reference range. Erythropoietin is low. White blood cells are also above the reference range, as are platelets. And our O2 stats fine. So which of the following is most likely cause this patient's condition? That should not be the first question that comes to mind. The first question should be, what's the diagnosis? When we see high hemoglobin and hematocrit and itching after hot showers, you know the diagnosis is polycythemia. We have additional red blood cells, the opposite of anemia. Polycythemia. Itching after hot showers is kind of pathognomonic for polycythemia. Everything else here really is, you don't even need it. You don't need anything else in this stem. Honestly, I don't even think you need this stem. Well, no, that's not true. You do need this stem a little bit. No, actually you don't need this stem. I changed my mind. Okay, so which of the following is most likely cause of patient's condition? Polycythemia can have multiple causes. There's primary and secondary polycythemia. So we have to figure out which is which. Let's say we don't even know which is which. What is primary polycythemia? What's secondary? I don't know. Let's see if we can get through this without it. Androgen use. So like taking exogenous testosterone. Okay, so testosterone use can increase your red blood cell count. That's very true. What does taking testosterone also do? It makes you jacked out of your mind. There's no mention of muscle mass here. And so honestly, it's kind of hard to tell on this one. I'm not sure. So I'm not going to cross that one off. I'm just going to move on and we'll come back to it. High affinity hemoglobin. Okay, so this is like hemoglobin fetal, right? HbF, fetal hemoglobin. I don't know. I don't remember anymore. Fetal hemoglobin would have high affinity, but why on earth would that cause polycythemia? Polycythemia is just more red blood cells. It's not necessarily high affinity hemoglobin. So this one doesn't make sense. I'm going to say this is a strong no for me. JAK2 mutation. What the heck's a JAK2? I don't know. Don't eliminate it. Just move on. We'll come back to it if we need to. Chronic hypoxemia. Let's think about that logically. First off, what is hypoxemia? What's hypoxemia? What's hypoxia? There's a difference. Hypoxemia is not enough oxygen in the blood. The emia part is in the blood. Hypoxia is not enough oxygen at whatever tissue you're talking about. Hypoxemia, not enough oxygen in the blood. That can cause tissues to become hypoxic. And then there's ischemia, which is a little different. That's lack of blood flow. Totally different, but and it's just an aside. So chronic hypoxemia. So if he had low oxygen in his blood, does it make sense that he would have more red blood cells? Well, yeah, that makes sense. Like if the body were to compensate and try to make more red blood cells to pick up as much oxygen as possible. Sure. Okay, this is a plausible mechanism. Why would he be hypoxemic though? There's a few reasons, right? Anything that stops oxygen from getting into the blood. So just think about that. What are barriers to oxygen getting into the blood? Well, let's start. The most obvious one is outside the body. What if you're in an environment with low oxygen? Okay, so like if he was living on Mount Everest, yeah, exactly. Well, he lives at sea level. There's plenty of oxygen in the atmosphere at sea level. There's not at high elevation. So that's not a good reason. Okay, so let's think then. Next step would be absorbing oxygen through his alveoli. So like COPD, something like that, some kind of lung disease. Well, this guy does not smoke either and has no known lung or heart conditions. Okay, I lied. You didn't need the stem. No known lung or heart conditions. He lives at sea level. It's probably not chronic hypoxemia. What about paraneoplastic EPO production? Well, good thing they told us. How much EPO he has? Not very much. So that definitely can't be it, right? He doesn't have any EPO. We see it on the labs. So now we're down to 2, A and C. Now, again, if you still have no idea what's happening, ask yourself, is it likely that this guy is juicing? Maybe. A 52-year-old bodybuilding, I mean, it's not out of the picture, but does androgen also increase white blood cells and platelets? No, it does not. But even if you didn't know that, like, that, does it make sense for androgen to do all of that? Hopefully you had an inkling about androgen use being related to EPO and red blood cell production. But now let's say we're getting a little more clinical here. Androgen use is just simply not correlated with increased white cells and platelets. But what about JAK2? Okay, this is a mutation. This could be anything. If we have no idea what JAK2 is, sure, that could be it. Either way, we've narrowed down to 2 answer choices. Is a great place to be. If you're absolutely not sure, just guess and move on. Save yourself the time. Here, though, we have polycythemia. We've confirmed it is not due to a secondary cause. That's what secondary polycythemia is, like hypoxemia is a secondary cause, right? We have polycythemia secondary to hypoxemia, or polycythemia secondary to androgens, but that neither of those anyways would explain the white cells and platelets. If you have primary polycythemia, or another name for it is polycythemia vera. This is me writing with a mouse, by the way. I'm awful at it. I'm sorry. Polycythemia vera is due to a JAK2 mutation. And what's unique about it, as opposed to secondary causes, is that it also can increase your white cells and your platelets. It's not just red blood cells. So the answer is C.